Ah, my head. Hi, my name is Derek Soon, and I'm a neurologist working in the west of Singapore. I see a lot of headaches. No, that's constipation. That's better, headaches. And so will you. A recent study published in The Lancet identified headaches as one of the top 5 causes of years lived with disability. Indeed, repeated studies on primary care consultations show headaches constitute between 5 to 10% of clinic consultations. This is perhaps unsurprising given the abundance of nociceptors in the head alone. Within the head, nociceptors can be found in the scalp, in the bone, the meninges, the blood vessels, the cranial nerves, the nasal mucosa, the eyes, and also even the teeth. Mechanical or inflammatory challenges to such nociceptors will lead to headache, what we would call secondary headache. The commonest headaches, however, are not due to structural or inflammatory processes. These are headaches for which there is no obvious identifiable cause, so-called primary headaches. Hypotheses abound on the root cause of pain, including changes in which the way the brain structures process pain. Structures like the posterior pons, the thalamus, the trigeminal ganglion, and the sphenopalatine ganglion have all been implicated. Functional modulation of such structures may provide potential treatment pathways in the future. This video aims to outline what to do with a headache patient who comes to your clinic, what to look out for, how to characterize the headache, how you should treat, and when to refer. In doing so, we will be following recommendations from the latest set of guidelines from the Headache Society of Singapore. This and other resources available on the internet, including ICHD3, will help to guide you in your path to managing headaches. Recall that this video, being limited in time and scope, cannot hope to provide a detailed description of headache or treatment. Instead, we hope to explore the general principles that underpin the headache consultation. Red flags and screening for sinister headaches. I still recall my first general neurology clinic that I performed in a clinic in West London. My consultant came up to me and said, "Derek, you'll be seeing lots of headaches. The main thing you need to be able to do is to screen the sinister headaches. Once you've filtered them out, you can manage the rest of their primary headaches at your leisure. That's a good lad." In other words, the headache consult should have as its primary aim the ability to sieve out the sinister headaches. These are the headaches that are serious, that would lead to permanent disability or death of the patient if we should miss them. Once the sinister headaches have been sieved out, we can then characterize the primary headache at our leisure. With this in mind, I started listing down all the sinister headaches. I classified them into intracranial pressure, onset, and other identifiable clinical features. I then analyzed them for features common to most sinister headaches and came up with 3 features: raised intracranial pressure, neurological deficit, and certain features in the temple. We will be looking at the 3 clinical features in greater detail. Raised intracranial pressure. The skull is a non-expansile box. Blood and CSF enter the skull, the blood through arteries and the CSF through the choroid plexus. And they exit the skull, the blood through veins and the CSF through the ventricular system. If there's an imbalance in the traffic, say for instance a blockage in the venous outflow, as you would get with the venous sinus thrombus, or a blockage in the ventricular system, as you would get with hydrocephalus, then you get raised intracranial pressure. Sometimes it's not an imbalance in the things going in or out of the skull, but rather something that's inside the skull that's not supposed to be there, like a tumor or a blood clot. In the context of raised intracranial pressure, headache results from mechanical irritation of the meninges, and the headache is worsened by anything which further increases the intracranial pressure. Things like coughing, straining, bending down, or lying flat. Some of the cranial nerves that run along the floor of the skull are particularly vulnerable to being compressed in raised ICP. These include the sixth nerve, the optic nerves, and the oculomotor nerve. Neurological deficit. Every conscious movement and sensation is underpinned by a neurological pathway. These pathways traverse the brain. Neurological deficits, when present in the context of headache, could very well mean a disruption to these pathways, as you would get with a bleed or a tumor. Tempo. Bleeds present acutely, normally arising over seconds. Tumors start mild and then they get relentlessly worse, often accompanied by constitutional features such as weight loss, neurological deficit, etc. Another very important red flag not mentioned in the above three is the presence of fever. If this is accompanied by confusion, neurological deficit, and or signs of meningeal involvement, these could all reflect a CNS infection. Other neurologists have also devised and published clinical sieves for sinister headaches. A widely used system is the Snoop system and its successor, Snoop 4, by David Dodick and colleagues.
Baby, you could be one. Let me change your life. I could show you many reasons, different seasons. Hop in my bag and I stay in it.
Well, how does one distinguish and diagnose primary headaches? The question one generally asks about headaches tend to fall into a handful of domains. Domains like the temporal and spatial distribution of the headache, the nature and severity of the pain, etc. One can use such domains as the main distinguishing elements in a table populated by the common primary headaches. Filling up this table, one can see that the primary headaches are adequately different from each other as to be easily distinguishable. One can then take this table and apply it in one's headache consult in clinic to aid diagnosis. Let's try it for this young lady who is coming with a headache.
Headaches about twice a week. They last around 6 to 8 hours. I cannot work like this. Normally more to one side. What does it feel like? Like my head is going to explode 8 out of 10. When they come on, everything feels super bright. Light bothers me. No, noise don't bother me, but I feel super nauseated. Slight movement makes my headache worse. If I can sleep during the attacks, then it makes it better.
Loving, she got it together. Switching it up when she want. Yeah, I seen it the day that I met her. Rocking it off like sweater.
I've also added a couple of scenarios with which you can test your diagnostic aid. Just freeze the videos at these time points. And if the headache doesn't fit into any of the common or familiar primary headaches, the International Classification of Headache Disorders, or ICHD-3 website is an invaluable resource. Principles of treatment. In general, treatment should be aimed towards quality of life, which does not necessarily just have freedom of pain as its only endpoint. Other aspects of patient's life, including their social and emotional state, will influence the headache, the patient's perception of pain, and his or her ability to cope with the headache. In addition, different headaches respond to specific treatments. For instance, cluster headaches respond to verapamil and oxygen therapy. Tension headaches respond to tricyclic antidepressants. This underlines the importance of proper diagnosis before considering treatment. In this video, I will use the treatment of migraine to showcase some of the considerations with respect to selecting treatment. Migraine is a good model to use as it is common and the broad principles used in selecting migraine treatment can be applied to other headaches. The treatment of migraine can be broadly divided into conservative and pharmacological measures, the latter employing medication to treat headache episodes and frequency. Conservative measures are aimed at empowering the patient to take control of their disease and can be divided into measures directed towards knowing their illness, such as keeping a headache journal, and also making appropriate changes to lifestyle aimed at reducing the activity and impact of the disease. The importance of a headache journal cannot be understated. It follows the ancient maxim as articulated in Sun Tzu's classic Art of War. If you know the enemy and know yourself, you need not fear the result of 100 battles. If you know yourself but not the enemy, for every victory gained you will suffer a defeat. If you know neither the enemy nor yourself, you will succumb in every battle. A strategic change in words later, and the genius and effectiveness of a good headache diary becomes more evident. I suspect Sun Tzu would have made a decent headache doctor. These days, apps like Migraine Buddy facilitate comprehensive and robust record keeping of one's headaches. The characteristics of each headache are journaled, and at the end of a period of time, the patient and doctor have access to a detailed longitudinal record of the patient's headaches, triggers, and even effectiveness of medication. These afford an intimate knowledge of one's headaches and help to guide and inform the tailored lifestyle modifications that will help to further reduce headaches. Most of us are familiar with abortive medication. These are the medications we take to stop a headache that started, and includes old favorites like Panadol, Nurofen, and Jack Daniels. When asking patients about their medication behavior, I often encounter this sort of response.
So, I don't really like to take medication. I'm scared I'll get addicted. When headache comes, I try not to take. Only when I cannot tahan, then I take Panadol extra. But no use lah, I vomit everything out.
Patients often tell me that they are reluctant to take medication early on in the headache, when the headache is mild. They'd rather wait till the headache has reached a significant severity, even to the point of testing their tolerance. Then they take the medication. By the time they take the medication, however, they find it ineffective. Another complaint encountered is that nausea and vomiting causes them to throw the medication up, again rendering it ineffective. In such situations, I reveal my Friday night identity as Captain Analgesia, and I counsel them as follows. Ma'am, think of your headache as a crocodile and your painkillers as a hammer. If you're going to use a hammer to kill a crocodile, it's wiser to do it when the crocodile has not grown to an unmanageable size and is still small. You've got a better chance of success then. So, when you have a headache, try to take your painkillers within the first 30 minutes of headache onset. That would be the equivalent of killing a baby crocodile with a hammer. If you're going to wait until the headache becomes massive, then it would be the equivalent of attacking a 2-ton monster with a teeny toy hammer. I don't think I have to tell you what could happen then. So remember to take your painkillers within the first 30 minutes of headache onset. Also, if you see anybody from Save the Crocodiles, I was never here. Also, if you're throwing up, I'll give you some anti-nausea medication with your painkiller. It will make you feel better and it will keep your medications down. One last thing, don't go partying after you've had your meds. Go to sleep. This gives you the best chance of stopping your headache. And what about this thing called an analgesia ladder? This would be the escalation of abortive therapy in the event that the analgesia tried is ineffective. And of course, provided that they are taking the analgesia correctly, See the last section on crocodiles and hammers. In general, I find Panadol effective for mild to moderate migraines, resorting to non-steroidals, and especially naproxen for the more severe ones. For those who cannot tolerate non-steroidals, COX-2 inhibitors make an attractive alternative. Triptans and ergotamines form the next tier, beyond which a referral to specialists would be in order for consideration of the newer interventions, including CGRP antagonists. Prophylactic medications are aimed at reducing the frequency and severity of headaches. They are taken every day, regardless of whether or not the patient has a headache on that particular day. We do not employ prophylactic medications unless the patient has more than one headache a week, or if the patient's headaches are very severe and disruptive to the patient's life. There is a host of agents used as prophylactic treatments. This table, taken from the 2023 guidelines of the Headache Society of Singapore, provides a good overview of the agents available. Each of the agents have their efficacies and shortcomings, and the guidelines go through each agent in detail. I would myself just like to pick out some of the agents I personally commonly use and apply them to our patient with migraine. The choice of medications is tailored to the patient's specific requirements and headache severity, titrating dose and watching both for efficacy and adverse effects. Questions are addressed and lines of communication are kept open. One of the best things you can do for your patient is to keep yourself accessible for questions and for support. When to refer to a specialist? In general, most primary headaches are managed adequately in primary care. However, if there are sinister features in the headache requiring further workup, or if your patient's headaches persist despite adequate abortive and prophylactic therapy, then perhaps it's time to refer your patient on for further workup and management. We're happy to see him. This concludes our video on headaches. I do hope you found it educational, informative, or at very least entertaining. Thank you for your attention.
Todos me dicen que me veo muy cansado, que si ando deprimido, que si ando agüitado. Siempre respondo que yo me siento chido, ando en mi camino, tocando y gozando. No tengo culpa que me llame el acordeón, no tengo culpa que me llame la cumbia. No tengo culpa que me llame el acordeón, no tengo culpa haber nacido pa' la rumba. Noche tras noche yo tengo que jalar, no pido nada, todo me lo he ganado. Por mi familia yo le voy a chingar, con la música siempre a mi lado. No tengo culpa que me llame el acordeón, no tengo culpa que me llame la cumbia. Y no tengo culpa que me llame el acordeón, no tengo culpa haber nacido pa' la rumba. No tengo culpa que me llame el acordeón, no tengo culpa que me llame la cumbia. No tengo culpa que me llame el acordeón, no tengo culpa haber nacido pa' la rumba. No tengo culpa que me llame el acordeón, No tengo culpa que me llame la cumbia, no tengo culpa que me llame el acordeón. Y yo qué culpa haber nacido pa' la rumba.